Hello and welcome to the topic Pleural Diseases in the module Respiratory Medicine. By the end of this topic, you should be able to define pleural diseases, discuss the epidemiology of pleural diseases, outline the pathophysiology and causes of various pleural diseases, outline the classification and describe the clinical manifestations of pleural disease, outline the investigations and discuss the principles of management and complications of pleural disease. Let's get started. So let's begin with our topic today by defining what is a pleural disease. A pleural disease is a condition that affects the pleura, which lines the lung and the chest cavity. Types of pleural disease include pleurisy, which is the inflammation of the pleura, pleural effusion, where there is collection of fluid abnormally present in the pleural space, and lastly, pneumothorax, which is the presence of air or gas in the pleural space. In this presentation, we will be focusing on pleural effusion and pneumothorax. Let's begin with understanding the epidemiology of these two presentations. So for pleural effusion, at least 1.5 million cases happen annually, and this condition is generally associated with malignancies as well as heart failure. In terms of malignancies, we can see 2/3 of malignant pleural effusions occurring in women, and the conditions are secondary to breast and gynecological malignancies. Also not forgetting SLE, which usually occurs in women, and for men, chronic pancreatitis or malignant mesothelioma, which is more common. As for pneumothorax, primary spontaneous pneumothorax commonly affects those aged between 20 to 30 years old, while secondary pneumothorax more frequently in patients 60 to 65 years. The associated factors include smoking, a tall and thin physique, pre-existing lung disease, for example, chronic obstructive pulmonary disease, asthma, cystic fibrosis, lung cancer, pneumocystis pneumoniae, or in short PCP, connective tissue disease like Marfan syndrome, and rheumatoid arthritis. Catamenial pneumothorax is another condition which can also occur where it happens between 3 to 6% of cases during menstruation, and it's thought to be caused by endometriosis within the thorax. Now let's take a look at the anatomy of the lung. Each lung is enclosed in a serous pleural sac that consists of two continuous membranes, which are the visceral or pulmonary pleura, which invest the lungs and the parietal pleura and lines the pulmonary cavities, and adhere to the thoracic wall, mediastinum, and diaphragm. In between visceral and parietal pleura is a pleural cavity. A potential space between visceral and the parietal layers of the pleura, and it contains a capillary layer of serous pleural fluid which lubricates the pleural surfaces and allows the layers to slide smoothly over each other during respiration. Surface tension created by the pleural cavity provides the cohesion that keeps the lung surface in contact with the thoracic wall. Moving on, for pleural effusion, it can be secondary to a transudative effusion where there is a combination of increased hydrostatic pressure and decreased plasma oncotic pressure. And another presentation would be an exudative effusion, which are caused by local processes that lead to increased capillary permeability, resulting in exudation of fluid, protein, cells, and other serum constituents. For pneumothorax, it can be tension, primary or secondary pneumothorax. In tension pneumothorax, there is a breach in the lung surface which will admit air into the pleural cavity during inspiration but will not allow any air to escape during expiration. The breach acts as a one-way valve. In primary pneumothorax, it happens without the presence of any underlying pulmonary disease. Hypothesis here is the lung inflammation and oxidative stress seen in smokers, causing degradation of lung tissue due to the imbalances of the enzymes and antioxidants released by the innate immune cells. However, in secondary pneumothorax, it occurs with pulmonary diseases such as chronic obstructive pulmonary disease or COPD, asthma, HIV, or also seen in patients with pneumocystis carinii pneumoniae. Now let's take a look at the causes of pleural effusion and pneumothorax in a form of a table as such. So as mentioned earlier, pleural effusion is divided into a transudative effusion and an exudative effusion, depending on the amount of protein that's present in the pleural fluid. So common causes of transudative effusion include heart failure, and this is the most common cause, hypoalbuminemia, secondary to liver disease, nephrotic syndrome, malabsorption, hypothyroidism, as well as Meigs syndrome. And as for exudative pleural effusion, it's commonly seen in infections secondary to pneumonia, which is one of the most common exudative cause, tuberculosis, a subphrenic abscess, connective tissue disease such as in RA and SLE, neoplasia, pancreatitis, pulmonary embolism, Dressler syndrome, and yellow nail syndrome. For pneumothorax, as they are divided into primary and secondary pneumothorax, all we have to remember is in secondary pneumothorax, it is usually secondary or following to an underlying lung disease. So let's talk about the type of pleural effusion and how they can be classified. Light's criteria is used for classification. In exudative pleural effusion, the pleural fluid protein is more than 30 grams per liter, and is in transudative effusion, on the other hand, the protein level is less than 30. If the protein level is between 25 to 35, Light's criteria should be applied. An exudate is likely if at least one of the following criteria are met, which are pleural fluid proteins divided by serum protein more than 0.5, pleural fluid LDH divided by serum LDH more than 0.6, or pleural fluid LDH more than 2/3 the upper limit of normal serum LDH. While for pneumothorax, it can be classified into primary, secondary, tension, iatrogenic, and traumatic pneumothorax. As for symptomatology, patients with pleural effusion and pneumothorax may present with somewhat similar. This is because the involvement of the pleural cavity or the pleural layers. As for pleural effusion, generally they come in with dyspnea, non-productive or productive cough depending on what's the underlying etiology, as well as chest pain due to the irritation of the pleura. And similar symptoms are also experienced in pneumothorax depending on the severity as well. So patients come in with chest pain, often pleuritic in nature, associated with dyspnea. Moving on to the clinical signs, the diagnostic and associated signs of pleural effusion include rapid shallow breathing, absent tactile fremitus, dullness to percussion due to the fluid accumulation, and decreased breath sounds on the side of the effusion. Classically, patients with pleural effusion can present with pleural friction rub, which varies from a few intermittent sounds to a fully developed harsh, grating, creaking, or leathery sound synchronous with respiration, and this is heard during inspiration and expiration. As for pneumothorax, the diagnostic and associated signs range from completely being asymptomatic to life-threatening respiratory distress, and these signs include diaphoresis, splinting chest wall to relieve pleuritic pain, cyanosis, an altered mental status change, which can also be one of the major signs due to hypoxia. And as pneumothorax is a respiratory condition, hence tachypnea, asymmetric lung expansion, absent breath sounds, hyperresonance on percussion, and decreased tactile fremitus are among the signs you want to look for in physical exam. Lastly, patients can also come in with cardiovascular signs such as tachycardia, pulsus paradoxus, hypotension, and jugular venous distension due to the rapid increase in intrathoracic pressure. Now, we will discuss the tests to be done in different circumstances. So in this slide, we will look at the diagnostics test followed by the severity test. The diagnostic test for pleural effusion will be, of course, first of all, looking or visualizing the effusion via an imaging study. And this is then followed by a pleural aspiration. So imaging tests that can be done are posterior and anterior chest x-rays in all patients, ultrasounds to aid in pleural aspiration, and it is sensitive for detecting pleural fluid septations. As a contrast, CT scan can also be used to investigate the underlying cause, particularly for exudative effusions, as there might be an underlying malignancy. The next test would be pleural aspiration, where ultrasound can be used to guide to reduce complications during the procedure. A 21 gauge needle and a 50 ml syringe can be used. Pleural fluid is drained and it's checked for the pH, protein, LDH, cytology, and also sent for microbiology testing. The lab result obtained will then be applied in the Lights criteria, where exudative pleural effusion and the protein level is more than 30 grams per liter, while transudative pleural effusion, the protein level is less than 30 grams per liter. Exudative is likely if pleural fluid protein divided by the serum fluid protein is more than 0.5, or if the pleural fluid LDH divided by the serum LDH is more than 0.6, or the pleural fluid LDH being 2/3 of the upper limits of normal serum LDH. Other characteristic of pleural fluid findings, such as low glucose in the pleural fluid, is quite suggestive of tuberculosis or bacterial infection. Raised amylase is suggestive of pancreatitis and esophageal perforation, and heavy blood staining is suggestive of mesothelioma, pulmonary embolism, or even tuberculosis. For pneumothorax, on the other hand, the diagnostic test would be an imaging study. Chest X-ray can be done to look at lung collapse, where there is linear shadow of the visceral pleura with lack of lung markings peripheral to the shadow. Also look for ipsilateral lung edge parallel to the chest wall and mediastinal shift towards the contralateral lung if there is tension. Ultrasonography, on the other hand, can be used to look for absence of the sliding sign, which is the movement of the two pleura during breathing. Also look for the absence of the comet tail artifact, which is a vertical air artifact that arises from the visceral pleural line, and the presence of the lung point, which is the location that the lung sliding and the absent lung sliding alternately appear. For the severity test for both conditions, an arterial blood gas should be done to measure the degree of acidosis, hypoxemia, and hypercarbia. Now, as we have discussed the diagnostic and severity sampling, let's look at whatever tests that can be done to exclude other underlying pathologies. Here again, for the case of pleural effusion, a diagnostic pleural fluid sampling can be done to associate if associated sepsis or pneumonic illness, and if the fluid is purulent or turbid or cloudy, a chest tube should be placed to allow drainage. If the fluid is clear but the pH is less than 7.2 in patients with suspected pleural effusion, this is still considered a complicated pleural effusion and a chest tube should be placed. For the case of pneumothorax, an esophagogram can be done if there is suspicion of esophageal perforation. To distinguish between a large bulla and a pneumothorax, a CT scan of the thorax can be done where it can indicate the underlying emphysema or emphysematous-like changes, determine the exact size of the pneumothorax, and confirm the diagnosis of pneumothorax in patients with head trauma who are mechanically ventilated, and detect occult or small pneumothorax and the presence of pneumomediastinum. We are now done with investigations, and now let's proceed with the part where the topic focuses on the principles of management. The first part of the management we'll talk about will be ways to relieve symptoms. So generally, patients would be tachypneic or dyspneic and requiring oxygen therapy due to hypoxia. So the ways in these would require oxygen supplement as well as pain relief such as NSAIDs if necessary. According to the British Thoracic Society, for primary pneumothorax, if the rim of air is less than 2 centimeters and no dyspnea, then you may consider to discharge the patient. Otherwise, attempt aspiration. If this fails, which is defined as more than 2 centimeters or still short of breath, then a chest drain should be inserted. For secondary pneumothorax, if the patient is more than 50 years old and the rim of air is more than 2 centimeters and or the patient is dyspneic, then a chest drain needs to be inserted. Otherwise, attempt aspiration if the rim of air is between 1 to 2 centimeters. If aspiration fails when pneumothorax is still greater than 1 centimeter, a chest drain should be inserted. So all patients should be admitted for at least 24 hours, and if the pneumothorax is less than 1 centimeter, then the British Thoracic Society guidelines suggest giving oxygen and admitting for 24 hours. For the case of iatrogenic pneumothorax, it has less likelihood of recurrence than spontaneous pneumothorax. So majority of the cases will resolve with observation, and if treatment is required, then aspiration should be applied. But this rule does not apply to ventilated patients as they will require a chest tube insertion instead. Now let's take a look at the indications for a video-assisted thoracoscopic surgery. This is indicated in patients with second-time ipsilateral pneumothorax. This procedure is indicated in patients with second-time ipsilateral pneumothorax, bilateral spontaneous pneumothorax, spontaneous hemothorax, persistent air leak, which is still persisting more than 5 to 7 days of drainage, and certain occupations, for example, pilots or divers. For patients who had pneumothorax, they should avoid smoking to reduce the risk of further episodes, as the lifetime risk of developing a pneumothorax in healthy smoking men is around 10% compared with around 0.1% in non-smoking men. Next is absolute contraindication to flying for a specific period of time. It is suggested that patients may travel 2 weeks after successful drainage if there is no residual air. The British Thoracic Society used to recommend not travelling by air for a period of 6 weeks, but this has changed to 1 week post-check X-ray. British Thoracic Society guidelines also state that diving should be permanently avoided unless the patient has undergone bilateral surgical pleurectomy and has normal lung function and chest CT scan post-operatively. So we are now done with the management and we shall proceed with the next section, which is complications. The immediate complications for pneumothorax include hypoxemic respiratory failure, respiratory or cardiac arrest, and hemopneumothorax. As for the short-term complications, you may expect to see a bronchopulmonary fistula, which could be one of the underlying causes as well, pneumomediastinum, pneumopericardium, pneumoperitoneum, and pyoneumothorax. Long-term complications of pleural effusion here, as we can see, include lung scarring and pleural thickening. So let's summarize pleural diseases which we have learned. Pleural diseases are conditions that affect the pleura, which lines the lung and chest cavity, and this include pleurisy, pleural effusion, and pneumothorax. Pleural effusion can be divided into transudative and exudative effusions, and for ranges which are between these two cutoff levels, you may use the Light's criteria to decide whether it is most likely transudative or exudative. Patients commonly come in with dyspnea, chest pain, and productive or non-productive cough, depending on the underlying pathology. Generally, imaging studies are the first step that would be done in order for us to pick up a pneumothorax or pleural effusion, and for diagnostic purposes, a pleural aspirate is required for pleural effusion. A chest tube is required to drain the empyema or complicated pleural effusion, and as for pneumothorax, a needle aspiration is required depending on the indications. A chest drain is required if patients are severely decompensated or if there's an underlying secondary pneumothorax. We have come to the end of this topic. Thank you.